morning, everyone. I'm so delighted to have an opportunity to talk to you all today. As has been said, I will be presenting on behalf of St James's Hospital in Dublin, Ireland, and I'll be speaking to you about the assessment of the quality, content and readability of online information available to patients based on osteotomies around the knee. So to begin, let's reflect on a few questions. Who, in the last 24 hours, has looked up something on the internet, and who believed everything that website told them? So, if this is you, you're not alone. You're in fact in the majority. The internet is estimated to have a penetrance of 93.7% by 2023, and 90% of people believe everything that they see on the internet. If the information that is available on healthcare websites is inaccurate or inaccessible to the patients at too high a level for them to understand, or the information is not what the physician is telling them, it can potentially damage the patient-physician relationship, result in increased healthcare costs, which can be associated with increased readmissions to hospital after the patient has had an operation, as they have been using Dr. Google to Google their symptoms post-op. It can be associated with increased complications, reduced compliance with post-operative regime, reduced patient satisfaction, as they just simply don't know who to believe, and a risk of developing patient or parental cyberchondria, depending on the age of the patient. When we consider that the internet will be available to 93% of the entire world's population, and that 90% of people are going to believe what's on the internet, I think we can all say that it is very important that the information available be accurate, accessible, and helpful to the patient. Osteotomies around the knee are a joint preserving type of surgery. They had lost favour previously due to the fact that we had so much success with our unicondylar knee replacements. New plates, new technology have seen a recent regain in favour in the last number of years. However, it remains a complex operation that patients may turn to the internet for a quasi-second opinion, or to simply get more information, or to answer questions that they developed after they'd had their consultation. As this is a complex surgery and one that has recently only returned to favour, it is thus very important that the information be up to date, accessible, understandable and timely for these patients, so that they're able to make the best choices moving forward with their surgeries and with their care. So the objectives of our study were to assess the quality of the content of the healthcare websites available on the internet in regard to knee osteotomy, and to assess the readability of the information available on the internet. So how did we do this? First of all, we started by identifying websites. So we picked a specific day and we ran through the four top search engines, Google, Yahoo, Bing, and Ask, for the phrases high tibial osteotomy and knee osteotomy. We did this based on the first 2 pages of each of these search engines, as previous research has shown that when people are scrolling through websites, they rarely go past the first 2 pages of a search engine looking for the information they want. Secondly, after this, we removed any duplicates. So websites that had turned up on Google, if they reappeared on Bing, we obviously excluded them when they returned on Bing. So that gave us 49 unique websites. We then screened those websites, making sure that they didn't require login, they didn't require fees, and they didn't simply have videos that were, we say, for technical companies, that were videos that were advertisements, and that led to us removing another 3 websites. And basically, after we had removed all the inaccessible websites for username and password, or that were excluded due to them being only video type websites, we were left with 45 websites which were for qualitative analysis. Each of these websites was then assessed using specific marking scores. For quality assurance, we looked at the Discern score, the JAMA score, and we created a bespoke knee osteotomy score. And for readability, we used readability software. The Discern score is a score marked out of 15 with a max score of 75 that is broken into two halves. The first half refers to the content of the website. Are there references? Are the names of the people who did the website on it? Is the content updated, and is it marked as updated on a certain amount of times? The second half of these questions, we'd say the subsequent 7, covers the information that is in it. Are the different treatments that are available mentioned? Are the different complications, the risks and benefits mentioned? And a score out of 75 is assessed. A score between 65 to 75 is considered excellent, 51 to 64 is considered good, 39 to 50 is fair, 27 to 38 is poor, and 15 to 26 is very poor. The JAMA score is 4 different criteria: authorship, attribution, currency, and disclosure. Authorship lists all the people who contributed to the piece. Attribution means that there were references, that the information where it came from has a source. Currency refers to the date that the information was posted and the information was updated. And disclosure means that if there was any sponsorship or advertisements, they were disclosed to the person reading the website. Our bespoke osteotomy score was developed in line with the guidelines of the American Academy of Orthopedics and was done in cohort with a fellowship trained surgeon. Contained 28 factors with a max score of 30. We also had checked for the presence and absence of a HON code. This is a non-profit organization that attempts to establish ethical boundaries and ethical standards of medical publishing. And websites that have achieved the HON code have a listed set of standards that they comply with. The readability software was checked for the reading grade level, which is to be under 6 to 8 as per the healthcare information in the United States. It should be about the 6th or the 8th grade level to ensure that it is accessible to all. For a European standard, that would probably be about a child at the age of 12, so the end of primary school. The second thing we looked for, apart from the readability score, was the Flex Reading Ease scale. And this scale was done based on the number of words in a paragraph and the number of words in a sentence and the number of syllables in each sentence. A score of 65 or higher is considered to be good. Now here I can show you our bespoke osteotomy score that we made in contribution with a fellowship trained surgeon and under the guidelines of the American Academy of Orthopedics. We had 28 factors with a max score of 30, allowing 2 for complications. So 2 points for complications, everything else was a 1. An excellent score was between 25 to 30, a good score was 19 to 24, a fair score was 13 to 18, a poor score 7 to 12, and beyond that was considered very poor, so 0 to 6. We have here the Flex Reading Ease score and how it breaks down. As you can see, a score over 65 is considered to be a good score and an accessible score. The higher the score, the better and more easy to read it is. The lower the score, the less easy to read it is. A score of 30 is thought to be online with the Harvard Law Review, so very difficult postgraduate type information. So after we had done all that, we then ran our results through SPSS, and we've broken down the results into quality and content and into readability. First, looking at the quality and content. The mean Discern score was 36.7. This classified the information that was on the internet as poor. So the majority of the content and quality of the information on the internet available about osteotomies was poor. Similarly, the mean bespoke knee osteotomy score was 15.4, which registered as fair. So the quality of information available was exceptionally poor. There was an awful lot of content missing, particularly an awful lot of the websites did not discuss complications. They were quite keen to speak about the benefits of having the surgery done, but they weren't keen to talk about different options or the complications that may have arisen. Websites that have borne the HON code, so the established list of standards and ethical practice, tended to have a higher discern, JAMA, and knee osteotomy scores. We also found that the best articles for content were journal articles. However, on the balance of this, they were exceptionally inaccessible to a patient who may not have had any formal medical training or may have only finished up to a certain grade and may not have the education to be able to read and decipher the information that was available. So the journals had good quality of content, but they were completely inaccessible. In terms of then the results for the readability, the mean reading grade level was 13.2. The United States Literacy Board say that information in terms of healthcare should be at a 6th grade level. So it exceeded the 6th grade level by 7.2 grades. The National Institute of Health say it should be between a 6th to 8th grade level, and it exceeded the 8th grade level by 5.2 grades. No website that we assessed during this project met the 6th or 8th grade reading levels. This means that all the information was inaccessible as per the standards set by the United Health Literacy Board and the National Institute of Health. This makes this information inaccessible to our patients, and it means that it can result in complications, lack of compliance, lack of satisfaction, and damage to the patient-physician relationship. The FLEC Reading Ease score, which we've discussed before, is required to have a score of 65 or higher to be considered good. The mean score was 41.13. This classified the websites as difficult. Journal websites had the highest reading grade level, which is not surprising. These were usually around 30 and were considered to be at the level of the Harvard Law Review. While they had the best content, they were inaccessible because the information was not attainable or understandable by a regular person. Our conclusions based on this is that there is a great variety in the amount of information that is available on the internet in regard to osteotomy. This information is unregulated and it varies in terms of quality, completeness, and accessibility. Even when high quality information is available, it is at too high a level to be understood, too high a level to be accessible, and is therefore not useful to the patient. Moving forward, we need to just demonstrate better leadership as physicians and better guidance for our patients. We need to ensure that our patients have access to high quality, impartial, and accessible information. This may mean that we develop our own resources and that we test them against the readability and content scores that we have seen in this discussion today, and that this may mean that we have to put in the effort to further spend time with our patients in consultations to make sure that we answer all their questions and provide them with timely, accessible, accurate information going forward. Until this happens, the best thing our patients can do is stay off the internet. Thank you so much. I'm happy now to take any questions that you may have.